Okay, let me get this. Oh, can you put my other, the other Matthew Cunningham Hill as a co-host?
Got it.
Thank you.
Yeah, should be good.
Hopefully everybody should be able to see the slides.
Yep, sure can.
Okay, so my name is Matthew Cunningham Hill. I'm one of the vascular surgeons up here at Ruby. Just a little about me. I'm from the Philadelphia area. I did my residency training at Temple University and actually did my vascular fellowship here at Ruby Hospital for the past 2 years. And I've been on staff here for 6 months now. So the topic today is discussing the role of vascular surgery in limb preservation. We'll kind of be going through what a vascular surgeon's role is, how we help to coordinate things, what we actually do in the operating room for these patients. And then I have a couple of multidisciplinary cases to discuss that will kind of highlight some of what we do as well as what the other specialties do in the care of these patients. So first and foremost, so why are we doing all this? Why do we care so much about limb preservation? As we all know, mortality rate post major amputation is bad. The vast majority of patients who undergo a major amputation have a mortality that rivals even the most aggressive cancers, with 44% mortality at 1 year, 66% at 3, and 85% at 5 years. This is really just an indication to just how sick these patients are at baseline. And an amputation is an index event for these patients that often will kind of lead to their eventual passing, unfortunately. So in striving for limb preservation, I think it's important to note that it's not just the vascular specialist who is the forefront of this. It takes an entire village of providers as well as inpatient, outpatient, and community experts. Here, just on the left, you see just a small smattering of the people that it takes to really get these patients through this process of limb preservation. The vascular surgery is often just a small part of that, and oftentimes it'll be several months both before and after a major surgery in order to have limb preservation, foot preservation, through endocrinology for diabetic care, for wound care, for helping to heal up these diabetic wounds, infectious disease to help manage infection in these wounds, nephrology to help manage comorbid conditions such as CKD, and then sometimes even the roles of plastic and orthopedic surgery, physical medicine and rehabilitation to help get these patients with offloading, get them up walking around again, the use of orthotists to help with getting appropriate footwear to help preserve wound healing, nutrition for both diabetic care as well as for optimization of patients' intake of nutrients, as well as social work. And I think another important part of this that's often not talked about as much is palliative care. I don't think these patients often realize quite how sick they are or how close, what the mortality of this disease process is. And I don't think a lot of providers do either, but palliative care for these patients will often help to kind of put into perspective just how ill they are and how severe the situation they are in. So the referral network, so what is really needed for a limb preservation team? The goal is really to engage the limb preservation team early. Podiatry and vascular surgery will help to evaluate what the primary threat to the limb is, whether that be infectious or ischemic, and we'll talk a little bit more about that later. This can be either an inpatient or an outpatient referral network. Oftentimes these will start as inpatient, and as we're now doing is branching out into the outpatient world to try and prevent these patients from having to always be admitted into the ED with a hot foot that is requiring immediate surgical intervention and putting the patient at risk for sepsis and other issues. If we're able to take care of these patients as an outpatient and keep these wounds from even presenting in the first place, is what all of this is for. So really what's needed for limb preservation and kind of what we're trying to establish here is the ability to perform both hemodynamic and anatomic vascular assessments. We have to be able to perform peripheral neurologic workup, which is what's done by the primary care providers with the foot exams that are being done. We have to be able to do appropriate cultures of these wounds. If we're going to direct antibiotic therapy, we need to be able to do appropriate cultures, which are often done by our wound care and podiatry colleagues. We had to be able to grade these wounds on the setting of both infection and ischemia, which is where the Wi-Fi staging system comes in. We had to be able to do the appropriate surgery or bedside debridement of these wounds, which can often be done in the wound care setting as an outpatient. We have to be able to provide appropriate antibiotic therapy that's it's appropriate for the patient as well as the organism that's being targeted, which is where our infectious disease colleagues come in. We have to be able to perform revascularization, which is where we as the vascular surgeons come into this. We have to be able to form soft tissue and bony reconstructions of these wounds, which again is where podiatry and orthopedic surgery come in. And then we have to perform, post-operative monitoring and reduce the recurrence of these, which is where the primary care providers, physical medicine and rehabilitation and physical therapy comes in. As you notice, only really one of those was vascular surgery. So I think it's really important to realize that the vascular surgeon is just a small part of this for these patients. So as we kind of talk about as we identify these patients and we're kind of managing these wounds, is really kind of the other part of this is the outpatient setting of how to prevent these wounds. And also once we actually get these wounds cleaned up, how do we continue to care for them? So the ongoing issue, and I know a lot of you guys work in the wound care clinics, I just heard, is a lot of this is outpatient care to manage this tissue loss. If we're able to minimize the tissue loss and manage these as an outpatient, either with serial debridements, offloading, total contact casting, treatments of the wounds beds, and assessing the vascular flow to determine the level of ischemia for these patients, it will lead to hopefully better outcomes for these patients. And again, this is not being done by vascular surgeons. This is mostly being done by our colleagues out in the wound care clinics. So this model that was kind of popularized by Armstrong et al. Kind of talks about this toe and flow model. So this was published in the Journal of American Podiatric Surgery, and it highlights the two primary referrals to these patients, to both the podiatrist as well as the vascular surgeon. With the vascular surgeon really being the key to reestablishing blood flow to these wounds in order to optimize the wound healing and the chance of a successful reconstruction by the podiatrist. But you'll notice here that it's not just these two specialties. We have both orthotists, we have orthopedic surgeons, general surgeons, diabetologists, or oftentimes these are just going to be primary care providers or endocrinologists who are going to be taking care of these patients' diabetes, infectious disease, and plastic surgery if it really comes to this. And a lot of this is all started by the primary care providers identifying these patients who have wounds, who have toe problems, who are really going to need the intervention of either a vascular surgeon, a podiatrist, or both. I found this quote, which I thought was kind of helped to really summarize what the main role of vascular surgery is, which is revascularization is a critical component in the management of patients with chronic limb-threatening ischemia, as insufficient arterial flow results in rapid tissue death and impediment of wound healing. So really the role of the vascular surgeon is to optimize the flow for these patients, to provide non-invasive testing, to provide the interpretation of those non-invasive tests, and to be an expert in how to get blood flow back to these wounds so that we have more success with our below ankle amputations, our reconstructions of the feet, of healing infections, of healing ulcerations, and getting these patients to a level of remission with these wounds so that they're able to keep their limbs and continue to live a productive life. So next, I kind of wanted to just talk to you guys about what happens when you identify these. Obviously, when these referrals get placed and you send patients to either the vascular surgeon or the podiatrist, depending on how your referral pattern is, I just thought it'd be interesting for you guys to have an idea about what we do, both inpatient and outpatient, give you some of the options that we offer to patients for reconstruction, and then the cases will help to kind of reinforce these. This is obviously a very basic model of this. So there's obviously, I could spend hours adding more and more lines into this and making it more and more complicated, but I thought that a basic outline would be be more helpful. So first, in most settings, these are patients that are identified by primary care providers. These are ulcers on wounds. These are black toes that have been identified. These are red feet that come into the ED, that come into the clinic, and the patient's having a fever. And so the foot exams that have been done in the clinics is where these wounds and these limbs are being triaged by the primary care providers. I know Dr. Mintz has provided education on this in the past with kind of how to triage these and which ones are threatened, which ones are emergent, and how we triage these into which of the next steps they have to go to in terms of if a patient is presenting with an acute limb, either with ischemia or an infection, and they need to present to either be admitted to the hospital or presented to the emergency department for source control or for revascularization. For instance, if you had a patient with wet gangrene comes into the office who's septic from that, they're obviously not going to be going home. We're going to be sending those to the patient to the emergency department because they're going to need further workup at that time. However, if you have a patient who has a black toe that's been there for 6 months, this is someone who's going to most likely be able to be referred out to either podiatry or vascular surgery, and ongoing workup will be have to done as an outpatient in order to salvage the remainder of this patient's limb. So when we find any of these patients, based on whether they are threatened or non-threatened, they'll either be an inpatient or outpatient referral. And then interestingly, a lot of the next kind of comes back to the same, it's just in different locations. For an outpatient, we often will have, if you're referring to vascular surgery, you'll often get a member of our team will reach out to you and ask you to order non-invasive testing, as we as vascular surgeons often need that in order to expedite care for patients. But if we haven't seen the patient, we can't legally order it. And obviously, when patients come inpatient, we're able to get that testing expedited because they're actually within the hospital where the vascular lab is located. So once you've had this referral to a surgical specialty of either vascular or podiatry, the next step is really to establish what the underlying disease process is, whether that be infectious, ischemic, or a combination of both. Unfortunately, as with most things, it's not normally cut and dry. It often requires some nuance, and often I'd imagine it falls squarely in the middle as the hybrid of those two things. Obviously, with each of these, though, it will change how we're going to manage these things. For example, if a patient presents with tissue loss, infection, and palpable pulses, the primary kind of surgical specialist being taking care of this is the podiatric surgeon. They're going to be addressing that lower extremity wounded infection. They may consult with us as well if they're concerned about blood flow, or if there's really no signs of any decreased flow to this limb, and really all that's needed is source control. Then podiatry is really going to be the major player in this, and then vascular surgery remains available if unfortunately these limbs are unable to be preserved and a more proximal amputation is needed. However, if, say, a patient presents with no palpable pulses, without any signs of acute infection, then oftentimes the first consult will be the vascular surgery. If revascularization is indicated, we'll examine to see whether the arterial inflow is good, the venous outflow. If there is a toe wound or if there is a wound on the foot, we'll often consult with podiatric surgery as well in order to get them involved so that we can help coordinate all of that care in an inpatient or an outpatient setting. And then if it's some kind of combination of the two, as you can imagine, it becomes a conversation between the two specialties. If the patient has a wound that is not going to heal because there's decreased flow, but there's also an element of infection, it really depends how severe that infection is, where that infection is, if it's tracking up, if it's making the patient systemically ill, if the patient's at risk of limb loss from that. And really, a lot of this is going to be dependent on each patient's individual presentation. And then the end goal of this obviously is limb preservation. And so just kind of to talk about some of the options that we have as vascular surgery, oftentimes these patients go to the operating room and we have 101 different ways to do the same thing, unfortunately. And so a lot of this comes down to provider preference. But in vascular surgery, there's really two main ways that we're able to fix things. Pardon me. So we have two major options. One is endovascular and one is open, and we'll talk about cases that include both of these later. The choice of the procedure is very much individualized to each patient and the disease process. Endovascular is often routinely done either as a diagnostic or a therapeutic. We're able to reopen stenotic areas or occlusions. We can establish better flow for a bypass. It can be a standalone procedure. It can be staged. We often are able to treat things with balloons, with stents. There's a multitude of different stents. There's a multitude of different balloons. It doesn't really matter what they all are. Just it's easy to remember just that there's balloons and stents, and that's how we really treat the inside of arteries. The next is an open operation. This is, the typical bypass, as you can see here on the left, going from the common femoral down below the knee all the way to the anterior tibial artery. The open revascularization really goes into the tenets of vascular surgery now, where we're talking about three things, which is the inflow for the bypass, the outflow for the bypass, and the conduit for the bypass. So really what we're doing with each individual patient is looking, how are we getting the blood in? Where is the blood going? And how are we going to get it there? Again, each one of these is very dependent on the patient, what surgeries they've had before, how good of a surgical candidate are they, what the wound is, where the wound is, if they're able to walk, what the status of their other limb is. And it comes down, to a lot of that. And then the last option is a hybrid approach, where say we have a patient with an iliac occlusion up higher, but also has a distal popliteal occlusion and needs revascularization below the knee. We may need to establish flow in via a hybrid approach by cleaning out the femoral artery, getting the iliac artery open, and then providing an outflow for that new inflow that we provided to below the knee in order to heal a wound on the foot. Again, unfortunately, with each one of these, it's often very different for every patient. And kind of you'll see that as we go through some of these cases coming up. So I thought the best way to really just kind of show what vascular surgery is able to do for some of these patients is to go through cases. So I have 3 cases to discuss. The rural patients over the last several years that demonstrate the multidisciplinary team and how it can all come together to help these patients with limb salvage. Pardon me. So the first patient is a 77-year-old female. She presented with a right hip fracture in early 2023. She underwent fixation and had been in a nursing home since that time. You can see here she has some notable risk factors for vascular disease, as well as some significant surgical risk factors, including this heart failure with reduced ejection fraction, hypertension, diabetes, chronic kidney disease, as well as coronary artery disease. Of note, this is a patient who in early 2022 had an A1C that ranged as high as 12. And in the effort to prevent wounds in this patient, her primary care provider had significantly improved this to around the time of surgery. She was actually at an A1C of 8, having shown a dramatic improvement in the outpatient setting. While the patient was in the nursing facility, she was started to be seen for a right foot wound, which we see right here. She has significant disease on that right fifth metatarsal head, as well as a plantar ulceration. She was started on antibiotics at that time. She had non-invasives done, which we'll go through next. And then the patient was sent to the ED because she had worsening of this wound to the point that it was now open. She had tendinous exposure. She had some redness on the forefoot there. And she was transferred to an outside hospital ED. As you can see here, she has two major wounds and a couple of minor things. The major wound is obviously this large open wound on the lateral aspect of the fifth metatarsal head here with exposed tendon. She also, as you can see here at the base of the fourth toe, has some ischemia. She also has this wound, this area right here, as well as some back here. General surgery saw the patient at the outside hospital and felt that the patient would be best served by transfer to WVU for optimization of the wound prior to try and salvage this limb. So part of her testing, once she was transferred here, included non-invasive testing, which in this situation was a ankle-brachial index, which is an ABI. On the right, you see over here, we see in the left leg that she has an ABI of 0.88, and on the right, she has one of 0.84. However, on the toe pressures on this right-hand side, you see is only 32, indicating that she has a poor chance to heal a wound, especially this far distal on her foot. So we spoke to both infectious disease and podiatry. She underwent a CAT scan, which was concerning for osteomyelitis of that fifth metatarsal head, as well as possibly the fourth. And so she was started on antibiotics. And these non-invasives, given the toe pressures, she was taken to the operating room for optimization of her vascular status, as it felt that the wound was stable enough to attempt this. I think if we didn't have we can kind of I'll get through the whole case. So intraoperatively, we took the patient. I can tell you that proximal to the level of the knee, which we see here, all of her vasculature was normal. You see the femoral rod that she has in place from her recent fracture. You can see that just below the level of the knee, at the level of the tibial peroneal trunk, she has severe stenosis of both the anterior tibial artery as well as the peroneal artery with an absent posterior tibial artery. She has a segmental occlusion of the anterior tibial artery. And then you can see after balloon angioplasty and treatment of this, she has significantly improved flow. You can see there's significantly less filling of the collateral vessels, and she has much improved flow down to the level of the foot. So she underwent balloon angioplasty of just these vessels. So this was, again, treated just with balloons, no stents. We often will not use stents below the level of the knee because we don't have them small enough, and we'd be using coronary stents, and they're just not long enough or durable enough for the vessels in the leg. So the patient then underwent a procedure with podiatry, and I'm not sure if any of the podiatrists, I think this was actually a patient of Dr. Bozier's, in a wound like this. In a wound like this, kind of the decision of like how to undergo this with an incision and drainage and this closed versus open wound vac. I'm not sure if you'd like to speak at all about that.
In this case, the patient had, if you saw the original wound, it actually looked, I tend to go pretty aggressive when I'm doing this type of washout with an amputation. And so my goal is always to get a clear proximal bone margin so that the pathologist can tell me I have a clear bone margin. So at least I know I've gotten, the bone infection under control. Unfortunately for this young lady, I think she had purulence tracking into her arch. So I tried to close primary as much as I could, which is the amputation site, but she ended up with some stab incisions, and I believe, if I remember right, she ended up with a wound vac on the arch of her foot because it just didn't feel at that time that it needed to be closed because there might have been some residual purulence going into her arch. But I think I did a pretty good job. At least her fifth metatarsal, her fifth partial ray resection looked pretty clean, at least clean enough to resect and close.
Perfect. And then, so the pathology for that, this actually came back, and she was actually without osteomyelitis. It was actually just she didn't have osteo, which was perfect. She actually had MRSA growing out of this wound. I don't think we had any from ID on, so we can just kind of continue. But you can see the wound came together nicely.
Oh, wait, you do.
Oh, I do?
Dr. Norialis here from UPMC.
Yeah, I'm on.
So I don't know if you'd like to comment on, on these diabetic foot wounds that we don't have osteo, especially once pathologically confirmed, kind of what your approach is to antibiotic therapy in these patients.
Yeah, that's a good question. I think we definitely heavily rely on paths to tell us. Typically, we have to just take it into the bigger context. If there was an imaging that was suggestive of osteo, and if, let's say, the path doesn't show it, we always kind of tend to wonder, is this a sampling issue that maybe the part that you sampled did not have osteo, but there could be osteo in a different part of the bone. So we definitely take it in context, but if we feel very confident that the source was well controlled, the proximal bone cultures are not showing osteo, then we treat it as a wound, a complicated wound infection. So we would still give antibiotics for about 2 weeks, if not longer. But the difference in the thought process is, for a complicated wound infection without osteo, we could definitely get away with oral antibiotics rather than trying to push for IV antibiotics, which we might do for a severe osteomyelitis case. So I would still probably give at least 2 weeks. And there's no right or wrong in terms of duration, but sometimes if the wound is still open at the end of 2 weeks and we are worried that another infection could be detrimental, sometimes I would keep them longer on antibiotics just to make sure that the wound completely heals up.
It's like you read my next slide. So this patient was exactly as you said, was able to be treated just with a 14-day course. They treated this as a complicated foot wound. She underwent with close follow-up, she was able to do oral antibiotics. And then from her pre-op, she continued to be monitored, and her A1C was even improved further from her initial pre-op of 8 down to 7, where she eventually came back to a nurse. She went back to the nursing home from where she came. Next, we see it 2 months post-op. You can see how well this wound healed up. So you see that the patient has more or less healed the surgical wound, that she has a small scar still on that right at the base of the surgical wound. That fourth toe is otherwise remains stable at this time. This case really kind of shows how the combination of the wound care providers who were seeing this patient in the nursing facility really escalated this case to the ED, where a general surgeon identified this wound as a problem. And you can imagine in a model where there isn't a real goal of limb salvage, and this wound was seen in a patient in a 70-year-old lady, that they may have just proceeded with a bologna amputation. However, this lady is now 4 months post-operative, has her foot, still has most of her foot as well, only losing a 5th ray. And with a combination of both infectious disease, vascular surgery, her PCP for diabetes control, as well as infectious disease, we were able to salvage this woman's foot. And you can see the significant improvement that we have from her from her first presentation to where she's now healed this wound. So the second case that I wanted to discuss, this is a 72-year-old female who presented with this right lower extremity non-healing wound, and I apologize for how close up it is. This is kind of at the distal aspect of the muscle belly on the posterior right calf. So this is a 72-year-old female who presented with a right lower extremity non-healing wound that had been there for several months, but had been progressively worsening with this discoloration, as well as some concern for infection. These scars were forming. And like I said, this was towards the just below the muscle bellies on the right calf, and was causing a significant pain. Now she has a history, again, of significant risk factors, diabetes and hypertension. And her PCP over the year prior to this had been working extensively with the patient. A year prior to this, her A1C had been 11. Within 3 months, that had actually been brought down to 7. And then at around the time of surgery, it had even been further optimized and was actually down to 5.7. And so they had really been working very closely with this woman in order to get her sugars under control. However, even with this significant improvement in her blood glucose control, she was still having this wound that was not healing. So she was eventually seen by the wound care specialists, and they ordered non-invasive testing as part of their workup to see if they could identify why this patient wasn't healing her wounds. So when the patient came to my clinic, she had these non-invasive testing that was performed. You can see on the left-hand side, she has fairly normal waveforms all the way down to the level of the ankle. She has moderate disease on the left, and she has severe disease on the right-hand side here. Showing some FEMPOP disease. She has a decreased toe pressure on the right-hand side of 33. And given that the patient had had no real significant healing of this wound, we took it to the operating room for an angiogram to see if we could optimize her chances of healing this wound. So we took the patient to the operating room. I can tell you again that everything above the level of the SFA, which is where we are here, was normal. Here we see the SFA, kind of the distal SFA, we see a segmental occlusion with reconstitution of flow. You can see all these collateral vessels here filling around. And then down in the tibials, we see this area of severe stenosis with a single perennial runoff to the level of the foot. So with this short segment stenosis, we were able to actually get across this. We were able to treat it with balloon angioplasty. This is the same segment. You see these branches here, these branches here. We were able to recanalize this segment and treat it just with balloon angioplasty to improve the flow to below the knee. We then also were able to treat this peroneal artery right here to improve this stenosis through here to improve the flow down the leg. Post-operatively, we see significant improvement in the patient's ABI, which previously had been 0.54 on this right-hand side, and now, as you see, it is 0.87 with a toe pressure of 105. And this is now the patient's wound. You can see the significant improvement she had. This was only 1 month after revascularization. And this wound is basically healed. Again, this shows that, the role of the vascular surgeon in this came in at the last month, so we can claim that we were the heroes. But really, all that really happened here was we were able to improve the flow, and with all the hard work that had been done by both wound care and the patient's primary care provider to get this wound, any infection that was present treated, and also to get her poorly controlled diabetes under control, is really what helped this patient to heal this wound. This wound would have been a severe problem because the location of this wound would have been on a flap for a below-knee amputation and could have caused this patient serious issues if this hadn't healed. It could have compromised the flap for a below-knee amputation, leading for a patient to receive an above-knee amputation when they really didn't need one. And so the last case is a 62-year-old male. This is a gentleman who has an extensive vascular history as well as medical history. So he'd undergone a prior femoral to below-knee popliteal bypass with plastic or PTFE after a failed endovascular revascularization. This bypass had failed multiple times. It required lysing open, which is where we place a catheter through and drip TPA in order to try and reopen the wound, reopen the area. He also has a past medical history significant for a pancreatic tumor, status post a Whipple, which unfortunately left him with diabetes. He's hypertensive. So he initially underwent his bypass back in 2019. He was then followed, and like I said, he had multiple lysis trips to keep this bypass open. During this time, he actually ended up with a Candida albicans right knee septic joint that was IND'd by orthopedics. And at that time, he was incidentally noted to have reocclusion of this graft with some cellulitis of the foot. He was minimally symptomatic from the graft occlusion, and the cellulitis really didn't look that bad, so we kind of left it alone. And so here you can kind of see the progression of that wound. On the left, you see just this mild cellulitis, and then over the next several weeks to months, you can see how this kind of developed into this almost abscess. And then I can't find any notes that decide when this guy had an IND, but this was obviously incised and drained at some point because you can see the incision up and down here. And so the patient now had this big open wound, an occluded bypass, and he was sent to the clinic. Given that he had this wound and we had a known occlusion of the bypass, he was sent to the ED because the concern was that this wound would not heal. He received a CT scan that then also at the same time unfortunately demonstrated that his distal anastomosis of his bypass had a rim enhancing fluid collection around it, therefore raising a concern now that he also had a prosthetic graft infection at the same time. So preoperatively, we planned and got non-invasives just to kind of prove that we really did have no flow down here. You can see this is an ankle brachial index again. On the left-hand side, you see as normal. We have normal waveforms with a dichrotic notch, and we can even see a good normal waveform all the way to the level of the toe. Whereas on the right, you can see there's really no waveform at the level of the ankle, and at the midfoot as well as the toe, these are flat toe line waveforms. And so the decision was made to proceed with surgery. So the patient underwent excision of his bypass graft due to the infection. So he had a femoral endarterectomy and patch. He had the whole piece of PTFE that was removed. And interestingly, again, and I'm gonna give you a hint, is that this again came back with Candida albicans in it, which was the same culture that had come back from the knee, and the culture from the operating room when I believe it was Dr. Kane took this patient and treated this wound also came back with Candida albicans.
Can I ask a question? Sorry,
absolutely.
This is Varadi with infectious disease. I was astounded with the first culture that you told me from the right knee of Candida. As an ID physician, when it's on the same side that you have a culture positive and a vascular graft that's occluded, it's almost 100% in my mind infected. So was he candidemic at that point, or was it just the knee that was positive?
He was not. It was just the knee, and he likely had Candida at the level of the graft at that time. And I'm not sure whether the graft was seeded at the time of the knee, but my guess is that he was not. But he never had any blood cultures that had Candida in them. But it is very interesting that the same species, the same Candida grew from both this foot wound, this vascular graft, and this knee infection. And so that was actually going to be one of my questions for you is, how do you manage? Candida is not a common infection that we see for these patients. Often we're dealing with MRSA, we're dealing with polymicrobial infections, but fungal infections causing multiple infections like this is not common from what I've seen.
And I'm happy to speak about it. I would let you finish your presentation, and then I'll be happy to speak about it.
Okay.
Yeah.
So we took the patient, and he had a redo bypass. He did not have saphenous vein, so he actually underwent it with a cryopreserved artery, which is a cadaveric vessel that is donated by a patient who was unfortunately passed away. He underwent a femoral to a posterior tibial artery bypass. He then subsequently went to the operating room with podiatry, and then Theraskin was actually applied to this after a washer and debridement. And so the other question I had, I'm not sure if somebody from podiatry would like to comment on this, just like on the role of Theraskin. We as vascular surgeons don't routinely use this, but in a wound like this, where this is a fairly gaping wound with concerns of infection, kind of the use of Theraskin and what how you manage that and what the decision is to use one of these adjunct type treatments.
Is Dr. Kane on or attending, since he was the surgeon? I mean, I can speak on Theraskin, but I didn't want to
see him.
Okay.
Yeah, this was
Don't
a
see him
case
on.
from about 3 years
Yeah.
ago. So.
So Theraskin is actually a split thickness skin graft from a donated living person. So it's not animal, it's human. And it gives us an opportunity to be able to offer a split thickness skin graft for a patient who probably wouldn't be a good candidate to harvest, like, let's say, from their anterior thigh. And so it gives you the scaffolding that you would need, but without having to put the patient through another, secondary wound that they would have to heal. What's nice about Theraskin too is that you can actually apply a wound vac over this, because this looks like it's fairly large but deep as well. And so, there's a lot of advantages, I think, in doing Theraskin. And we do keep it here. I spoke with a oculoplastic surgeon who's a big Kerecis fan, it's actually a fish product skin. But we like the Theraskin. We have it here. And, so long as the wound bed is clean and there aren't, and there's good blood flow, I think it's a really good way to do a primary as opposed to doing serial grafting. So that's really what this is. It's an opportunity to be able to do a primary skin graft without having to, have them come in every week to apply something that may or may not last.
Okay, thank you. And then is it Dr. Narulia? I was just wondering, kind of the comment on you were saying about the multiple kind of sites all in one extremity of candidal infections.
Yeah, no, I'm happy to speak about that. So just before I start, this gentleman, did he have diabetes?
He did. It was actually secondary to his Whipple procedure from his, he had a neuroendocrine tumor and actually developed diabetes after his pancreatic resection.
And I think now that I remember, you said that A1C was about 8.
Yes.
Okay. So Candida is a skin bug, like MRSA, like MSSA, like staph epidermidis. If you have one skin bug that can go in and cause an infection, Candida can go in and cause an infection as well. So the question is, who's more at risk for Candida versus an MSSA or an MRSA infection? Patients with diabetes, poor vascular flow, we always think of fungal. This is a kind of a unique case, but what just triggered me when you said the right knee had septic arthritis, it's very rare to see septic arthritis of a joint from a fungus like Candida. A native joint, which has never been entered in, should not have Candida without having candidemia. Usually it's like a hematogenous spread to the joint. So then the question becomes, why did the knee get infected? What is going on in that side that's making the skin and soft tissue prone to an infection? And the only clues that you have is that there is a prosthetic material or graft in that side. And if that graft is occluded or causing problems, you almost always have to wonder whether the skin pathogen entered through the breakdown, went up the graft, caused a problem. There's occult candidemia, and now that's infecting the joint. some patients, for some reason or not, we never recover Candida from the blood. It can depend upon the blood culture technique. We have a new test called T2 that we do. It's not new. It came on when I was in my fellowship, but it's a Candida PCR. And the reason that PCR was made was because sometimes the culture techniques don't pick up Candida well. And we can pick up the DNA of Candida from blood with that test, and we use it in our transplants and immunosuppressed population where we have a high, concern about candidemia. After a native septic joint, was this person kept on fluconazole for a long time, or was it just a short, like 1 month treatment or 2 month treatment?
Was just a 1 month treatment, and then at the end of the 1 month treatment is when the wound on the foot started.
Right. So I'm not surprised, because he probably had septic thrombophlebitis of his entire leg from Candida, because I think the source of the knee came from a venous contiguous spread. So if in retrospect, the way we would have managed this case, I think would be, from an ID perspective, what I would have done differently would have been probably very aggressively look for any signs and symptoms of a graft infection. And even if it wasn't there initially, followed it up with another study to see if there was a change in like 2 weeks of treatment or 3 weeks of treatment. And almost definitely I would have never taken this guy off fluconazole, because the concern is that there is a graft material, a foreign material which Candida loves to latch onto, and you don't have source control yet. So you can assume that it's going to spread till you have your source control. And native joint infections with fungus, we sometimes keep these patients on treatment for a year, if not longer, because Candida can be very, very hard to eradicate.
Did this patient end up like in the infectious joint clinic? Because there's like a bunch of ID people that are running some infected joint clinic with ortho.
I don't believe so. This patient was actually also from 4 years ago now, so
Yeah,
it
okay.
may not have been present at that time. So just to kind of give you the kind of the end here. So the patient after this event, the graft was taken out. He now just had cryopreserved vein through the leg. All the plastic was removed. He was actually placed on fluconazole for 4 weeks for treatment of this, including the foot wound. And then 6 months post-operatively, we see here the wound continued to heal significantly. And then 2 years post-operatively, you can see this wound is basically healed. You'll also notice the patient still has both of his legs, which I think is really very important for this. The bypass re-occluded in this patient, and he just has claudication. But once the wound is healed, the bypass is not really needed anymore. This is another one of those where it really kind of shows that this multidisciplinary care once again allowed this patient to keep both of his legs. He underwent a bypass at one point. This bypass was then infected. It took, he had a septic knee, so this was managed by both orthopedics, infectious disease, podiatry. He then also subsequently underwent PCI and a cabbage for coronary artery disease. So he's also being seen by cardiology and cardiothoracic surgery, just to kind of show you the level and the number of people that are required in order to save one leg can be astronomical. But for this patient, that one leg may mean the difference in the rest of his life. That's all I have for you. If there's any questions, I'll be happy to answer them.
I think thank you so much. That was awesome. Clap, clap, clap. That last patient, I think, again, the fact that he ends up with a cabbage and a PCI and all that stuff just highlights that this is, again, a marker for significant full body disease. It's not just the foot, which from the primary care standpoint, I think is important to remember. And then the other thing about the bypass occluding, so I think this is an important distinction for folks to understand, is that particular conduit, so we do bypasses with all different materials. So we have prosthetic materials like BTFV or Gore-Tex grafts. We have materials where we're using the patient's own vein. And then we have like these donor veins, which is the cryo vein. And depending on the situation, like we definitely worry about these Gore-Tex grafts getting infected. the veins are not, they typically don't get infected. And the cryo veins, we often will put in the setting of infection because they're supposed to be resistant to infection. We'll use that if they don't have vein. But they also kind of suck. And this is going on YouTube, and I don't know, the company will come after me, but they, not that they suck, but they go down, they occlude. That's their problem, but we don't really care usually when they occlude because we're typically using them in the setting of just stay open for 6 weeks so we can get something healed. And then if it goes down, it's usually not an issue.
Dr. Cunningham, I had a question for you. I'm hoping you can
Yes.
answer, Dr. Mintz. Sometimes I'll see patients where you guys take them to the OR and you're not necessarily doing like an angioplasty or stent, but you're putting them on a shockwave table or something like that. Can you explain what that is, like, and what the goal of that treatment is and why you would do that versus, other type of modalities?
Absolutely. So the shockwave lithotripsy is a newer product that's come out. It is still an intravascular shockwave. So it still is a balloon angioplasty, but the system is actually hooked up to a
Lost him.
Ultrasound device that
Yeah,
sent
yeah.
shocks within the from the balloon. It's just another modality that we use. He's coming back, but it's cool. It's really good in really calcified vessels. And they have a new tibial product that's coming out that we've been liking it. It helps the balloons work better. So we'll shock with that balloon first, and then we'll do our treatment. Because again, a lot of these patients with diabetes and renal disease in particular have extremely calcified vessels that makes it very hard to balloon and do things like that.
Oh, thank you for the clarification. I guess I think lithotripsy is, like a totally different type of procedure. So thank you.
Yeah, it's kind of like what they do with kidney stones. They shock them and break them up. We kind of do that with the calcium in the walls in a gentler, more controlled fashion. I think from the primary care perspective, there's always the question of, does it go first to, who to send it to? And from the podiatry perspective, the timing for revascularization, when you guys are doing the procedure and this coordination of care. I am curious from the primary care doctors, how do you coordinate this stuff? And how do you get the information from us when things have happened? Can any of the primary care doctors let us, because we're just oh, primary care, they're coordinating all of it and we're just doing our parts. But, is that in reality your experience, or how do you kind of keep tabs on these patients when things have been done and where they need to go next?
Well, I guess a lot of times in my experience, patients have to have a close follow-up with us because sometimes we rely heavily on consult notes. So, if we send them somewhere, we rely on them to let us know what's going on because a lot of the times the patients don't know. So that's how I keep tabs on and close follow-up, following up every month or every couple of weeks if we have to.
I was gonna say we're lucky to have a follow-up bucket to know if we referred someone out, let's set an alarm. Did they go to the appointment? Whatever, that kind of helps keep us on track too. So
are you looking, it comes up in your chart as an alert, or is there a navigator that's looking to make sure it happens?
the navigators.
When I worked in primary care, I usually kind of sent out my referrals to podiatry, vascular. I kind of did everything all at once. And then usually I would get some kind of paperwork back from vascular, a fax back in podiatry. And then but sometimes, I would have the patient come back really soon, and sometimes I would hear from the patient. There really is no perfect system. And I think that we always would get word back from WVU much faster than any other kind of healthcare organization. So that was really helpful. But oftentimes the patient would, let me know, what was going on.
Looks like Dr. Cunningham Hill is back. Does anyone have any more questions for him?
Yeah, sorry, I disconnected myself.
And I mean, ideally, it would be amazing if we had like literally a one-stop shop where the patients could come see us all. That's kind of the point of the multidisciplinary limb preservation clinic setting. In all transparency, we don't quite have that set up at WVU. We would like to, but we don't. However, our wound care is housed in the same clinic space as vascular. So up in Morgantown, it does give us that kind of, if there's something we're really worried about, we may ask, wound care to look at it. But even in Morgantown, it's hard to coordinate because everybody's kind of running on their own schedules. I don't know if Dr. Diamond, do you have any comments there?
Not really. I mean, I think from like you said, everybody kind of has their own clinic. We're trying to coordinate really through looking at the chart, and our wound care, is kind of primary care based. I would say coming from primary care setting, we got patients going to so many specialists, and I mean, it's not set up like surgery clinic where you often have a single person following up on every single person that you're seeing. So you do rely, at least when I did primary care, it may be different how you guys run your clinics, but when they're coming back, often when I transfer that care to a specialist or whoever's going to do it, they would, maximize what they do and then send them back. And, whether it's put them on medication, do a treatment, and then the primary care or fulfilling those basic needs. I think when it comes with these wounds, you got to consider a wound care center because these people need supplies, and you can do all these interventions, but again, if they don't have supplies and you don't have treatment for, when you revascularize and there's still the wound there, you still got to do the daily in and out treatments are required. And I think that's, like I said, I never had a person in my primary care be able to follow up every cardiology, actually that's, if they came back for it, or we would often transfer the care to the specialist until they were completed with what they needed, if they maintained it, and then it came back to us.
Okay. Anyone else have any questions or comments? Okay. We may be sending out just some evaluation requests kind of at the midpoint at this point of this program. So it will make it really short. It should be something you can do like on a Survey Monkey or something. But please keep your eyes out for that, because we're halfway through the program. If we want to make any changes, if there's a subject that, you really want to dig into, that would be more appropriate as primary care physicians, like this is for you. So please let us know if there's anything specific.
Thanks everybody for joining. We'll go ahead. It's 1 o'clock, but the next session is going to be on February 20th. So we'll see everybody then. All right. Take care.
Thanks.